Welcome to the deep dive. Today, we're taking a shortcut uh, deep into the body's sort of hidden operating system, the autonomic nervous system, the ANS.
That's right. It's the control center that's always running in the background, managing your heart rate, breathing, digestion,
Yeah,
stuff you don't consciously think about.
exactly. And our mission today, it's really about foundational pharmacology, isn't it?
It absolutely is. We want to decode the ANS, how it's organized, the wiring, the chemical messengers,
Mm.
because honestly, if you get this structure, you're well on your way to understanding how almost all the major drugs work. For the heart, lungs, gut.
It's the key to unlocking how those drugs manipulate that delicate balance.
Precisely.
Okay, so let's start with that organization. The big picture. Everyone sort of knows the two main sides, right?
Right. You've got the sympathetic system, that's your classic fight or flight, think energy expenditure, getting ready for action,
Mobilization.
mobilization. And then there's the parasympathetic system. That's the rest and digest side. It's all about conserving energy, maintenance, chilling out, basically.
And the way they're built, their anatomy, that really shapes how they work, doesn't it? That difference is super important for understanding things.
Oh, absolutely critical. Let's look at the parasympathetic wiring first.
Now,
The ganglia, those are the relay points, yeah. They're usually located really close to the organ they're controlling. Sometimes they're even embedded right in the wall of the organ.
okay.
And what that means is the postganglionic fibers, the sort of final messengers, they end up being pretty short. This leads to a very localized, very targeted effect.
Okay. So it's like a direct pinpoint instruction to one specific place, like sending a very specific text message.
That's a great analogy. Now compare that to the sympathetic system. It's ganglia. They're clustered way closer to the spinal cord.
Right, the sympathetic chain.
Exactly. So this setup means you have these really long postganglionic fibers that can branch out a lot. This extensive branching is what allows the sympathetic system to just discharge as one massive unit.
So that's why when you get stressed or scared, everything seems to happen at once. Heart pounds, breathing quickens.
Precisely. It's designed for that widespread, simultaneous, body-wide response. One
Yeah.
signal goes out, and boom, the whole system lights up.
Okay, got the wiring. But signals need chemicals, right?
Yeah.
What are the messengers doing the talking here?
Good question. We basically have two main chemical classes. First up, cholinergic nerves. These guys primarily use acetylcholine, or ACE.
Hi, okay.
And a really crucial detail here is how its action is stopped, how it's terminated. It happens very quickly through an enzyme called the acetylcholinesterase, or ACE. It gets metabolized, broken down super fast.
So the signal is grief, doesn't just hang around.
Exactly. Keeps things precise. Then on the other side, you have the adrenergic nerves. They mostly use norepinephrine, or NE.
Okay.
And NE's action stops differently. It's mainly taken back up into the nerve terminal, sort of recycled for later use, or it gets broken down by an enzyme called monoamine oxidase, MAO.
Recycling versus rapid breakdown. Interesting difference.
It is. And we can't forget the adrenal medulla before we move on. It's kind of like an honorary member of the sympathetic team.
Right, the exception.
That's our unique exception, yeah. The adrenal medulla basically acts like a modified sympathetic ganglion, but instead of sending a nerve signal, it dumps this really potent chemical mix straight into the bloodstream.
The famous adrenaline rush.
Pretty much. It's about 80% epinephrine, that's adrenaline, and 20% norepinephrine. This systemic flood just reinforces that whole sympathetic discharge. It kicks everything up another notch.
Okay, chemical sorted. Now, where do they land? And how do drugs mess with those landing spots? We need to talk receptors, the locks for these chemical keys.
Definitely. Let's start with the cholinergic system again, ACH receptors. Two main types, nicotinic N and muscarinic M.
N and M.
And the speed difference here is fundamental. Nicotinic receptors, they're ionotropic,
Ionotropic,
meaning when a troche binds, it directly opens an ion channel in the membrane. It's like flipping a switch. The response is incredibly fast, fractions of a millisecond. Instantaneous.
Wow, okay, like a direct electrical effect almost.
Pretty much. Now, muscarinic receptors, the M type, they're different. They're metabotropic.
Metabotropics, slower?
Much slower, relatively speaking, measured in seconds, not milliseconds. They work through G proteins and second messengers inside the cell. It's a more complex cascade.
So that allows for more, modulation, fine-tuning.
Exactly. That complexity is why the cholinergic system can have these more subtle modulatory effects on different processes.
Okay. And the adrenergic receptors, the targets for NE and epinephrine, alpha and beta, you mentioned they're also metabotropic, G protein coupled.
That's right. All the adrenergic receptors, alpha-1, alpha-2, beta-1, beta-2, they all use G proteins.
Can we maybe break down those G proteins a bit more clearly like we did for the M receptors, linking them to function?
Yes, absolutely. This is super helpful for pharmacology. There's a nice pattern. Alpha-1 receptors, they couple via the GQ protein, just like M1 and M3 cholinergic receptors.
GQ, that usually means activating something inside the cell, right? Like increasing calcium.
You got it. Leads to smooth muscle contraction, for example. Then, alpha-2 receptors use the inhibitory G protein, again, similar to the M2 cholinergic receptor.
G for inhibitory, makes sense.
And then all the beta receptors, beta-1 and beta-2, they couple via G's protein, S for stimulatory. This generally ramps up activity within the cell, often by increasing cyclic AMP.
Okay, wait. Let me see if I have this. Alpha-1 and M1, M3 use GQ, generally activating. Alpha-2 and M2 use G, generally inhibiting. And the betas use Gs, generally stimulating.
That's the core symmetry. Knowing that helps you predict effects. GQ often means contraction. G often means slowing things down, like the heart rate with M2. G is often means stimulation, like increasing heart rate with beta-1 or relaxing airways with beta-2.
That actually makes connecting the molecular stuff to the actual function way easier. Vasoconstriction, heart rate changes, bronchodilation. It clicks into place.
It really does bridge that gap.
Okay, perfect. Let's switch gears then and talk about the drugs. Starting with the ones that mimic that rest and digest system. The parasympathomimetics, the cholinergic stimulants.
Right. These drugs enhance the parasympathetic effects. They fall into two main groups. First, you have the direct-acting agents.
Direct meaning.
Meaning they physically bind to the cholinergic receptors, either nicotinic or muscarinic, and activate them directly. Think of things like the alkaloids pilocarpine, a key example, or some choline esters.
They pretend to be acetylcholine, basically.
Pretty much, yeah. Then you have the indirect acting agents, and these are quite clever in how they work.
How so? They don't hit the receptor.
Nope, they don't touch the receptor itself. They are cholinesterase inhibitors, drugs like edrophonium, the carbamates, or the really potent organophosphates.
Ah, they block the enzyme, HEW.
Exactly. They block ACE, the enzyme that normally breaks down acetylcholine. So the ACH that your own body releases just hangs around in the synapse for longer and at higher concentrations. It amplifies the natural signal.
So you're boosting the body's own ACE signal everywhere it's released. Is that maybe less precise than a direct drug? What's the clinical thinking there?
That's a great point. It is inherently less selective because you're juicing up a psych activity at potentially all muscarinic and nicotinic sites where ACA is active. The upside can be efficacy. Sometimes you need that broad system-wide boost.
Right.
But yeah, direct agonists like pilocarpine might offer more specificity if they have a preference for certain receptor subtypes, or if you can deliver them locally, like in the eye.
Speaking of subtypes, remind us quickly about those muscarinic agonists again. M1, M3 versus M2.
Sure. Remember, M1 and M3 receptors use that GQ pathway. This increases IP3 and DAG, leading to a release of calcium inside the cell. In smooth muscle, like in your gut or bladder, that means contraction.
Kind of contraction.
But M2 receptors, which are prominent in the heart, they use the inhibitory G protein. Activating M2 actually slows down the heart rate.
Okay, so very different outcomes depending on the M subtype targeted. So where would we use a direct-acting drug like pilocarpine clinically?
Pilocarpine is really important in ophthalmology. It's a tertiary amine, which means it can get into tissues easily, like the eye. We use it as a miotic agent. It constricts the pupil.
Meiosis, okay.
And crucially, by doing that and affecting other structures, it helps drain fluid from the eye, decreasing the intraocular pressure. So it's a key treatment for glaucoma.
Makes sense. Now, what happens if you overdo it, if that whole system gets too stimulated?
That's the cholinergic crisis or cholinergic poisoning. It's basically the parasympathetic system going into overdrive. All the effects become exaggerated.
So, like?
Think dumbbells. Sometimes people use that mnemonic. Diarrhea, urination, meiosis, pupil constriction, bronchospasm, bradycardia, slow heart rate, emesis, vomiting, micromation, tearing, salivation, sweating, essentially massive activation of GI tract, glands, bladder. Not pleasant.
Definitely sounds unpleasant. Okay, so conversely, what if we want to block the rest and digest functions? We'd use parasympatholytic drugs, the cholinergic antagonists. Atropine is the big one here, right?
Atropine is the classic prototype, yes. It's a powerful, non-selective anti-muscarinic agent. It blocks M receptors. And because it's non-selective, its effects are widespread.
So what does blocking M receptors do? Let's take the eye, for example.
In the eye, it does the opposite of pilocarpine. It causes the pupil to dilate, that's called mydriasis, and it paralyzes the muscle responsible for focusing the lens, which is called cycloplegia.
Difficulty focusing up close. Right?
Exactly. In the GI and urinary tracts, the effects are also significant. It markedly reduces salivation, leading to that classic dry mouth. And it relaxes the bladder wall, which can cause urinary retention, difficulty peeing.
And the heart. The parasympathetic system usually slows the heart via M2 receptors, so
Yeah.
blocking that.
You'd expect tachycardia, a faster heart rate. And generally, that's what happens at therapeutic doses. It blocks the M2 brake on the heart's pacemaker, the sinoatrial node. Interestingly, at very low doses, it can sometimes cause a brief slowing of the heart, a paradoxical bradycardia, before the tachycardia kicks in.
Huh. Complex. And what about the brain? Can atropine get in there?
Oh, yes. At higher doses, atropine easily crosses the blood-brain barrier. This can lead to CNS effects like restlessness, confusion, even hallucinations and delirium. Mad as a hatter, blind as a bat, red as a beet, hot as a hair, dry as a bone. That's the old saying for atropine toxicity.
Wow. And you mentioned something earlier about kids being particularly sensitive.
Yes, that's a critical point from the sources. Children are especially vulnerable to a rapid increase in body temperature hyperthermia that atropine can cause. It messes with sweating and thermoregulation.
Scary. Is there an antidote if someone gets atropine toxicity?
There is. You can carefully administer low doses of a cholinesterase inhibitor, like physostigmine. Physostigmine can cross into the brain too. By boosting ACE levels, it helps compete with atropine for the muscarinic receptors and overcome the blockade.
Fighting fire with fire, in a way. Boosting the natural chemical to outcompete the blocker.
Exactly.
Now, are there modern uses for these anti-muscarinic drugs beyond, say, eye exams or treating bradycardia?
Oh, definitely. A really important area is respiratory medicine. Inhaled antimuscarinic agents are mainstays in managing COPD, chronic obstructive pulmonary disease.
How do they help there?
They cause bronchodilation, opening up the airways. And a key advantage is that they do this without causing the typical side effects you might get from stimulating the sympathetic system, like the tremor or heart rhythm issues often seen with beta-2 agonists.
Ah, so targeted lung effects without system-wide sympathetic buzz. Makes sense. Okay, let's pivot now to the sympathetic side stimulants, the sympathomimetics. These are the drugs acting on those alpha and beta adrenoceptors we talked about.
Right. The fight-or-flight activators. We can start with a really important direct agonist, epinephrine. Adrenaline.
The rescue drug for anaphylaxis.
Absolutely. And think about why it works so well there. Anaphylaxis involves massive histamine release, causing bronchoconstriction, airways tightening, and vasodilation, dropping blood pressure. Epinephrine is perfect because it hits multiple receptors. It must activate beta-1 receptors to stimulate the heart and support blood pressure, and it must activate beta-2 receptors to cause bronchodilation, relaxing those constricted airways. It's a multitasker.
So it counters the key life-threatening features directly. What about indirect sympathomimetics? You mentioned cocaine earlier.
Yeah, cocaine is the classic example of an indirect acting sympathomimetic. It doesn't directly activate the receptors. Instead, its main action is to block the reuptake transporters for catecholamines, especially norepinephrine and dopamine, back into the nerve terminal.
So messengers just stay in the gap, keep signaling.
Exactly. It prevents their removal, so they build up in the synapse and keep stimulating the postsynaptic receptors much more intensely and for longer. This leads to those pronounced stimulant effects, the euphoria, the mental alertness, the increased energy, similarly in some ways to amphetamines, which also interfere with catecholamine handling.
Intense. And we also touched on dopamine itself having this weird dose-dependent effect. Can you recap that?
Yeah, dopamine's fascinating. It's not just one effect. At the lowest infusion doses used clinically, it primarily hits dopamine D1 receptors, particularly in the kidneys. This causes vasodilation there, which can be useful to improve renal blood flow.
Okay, low dose equals kidney D1.
Then, as you increase the dose, it starts hitting beta-1 receptors more. Now you get cardiac stimulation, increased heart rate, and contractility.
Medium dose, heart beta 1.
Right. And if you push the dose even higher, then it starts to predominantly activate alpha-1 receptors throughout the body. This causes widespread vasoconstriction, which increases blood pressure.
High dose is systemic alpha 1. Wow, so its personality totally changes depending on how much you give.
Completely. It's a really clear example of how receptor selectivity can be concentration dependent.
All right, finishing up our tour. The blockers of the fight-or-flight system. The sympatholytics or adrenergic antagonists.
Let's start with the alpha blockers. We can divide them based on selectivity. First, the alpha-1 selective blockers like prazosin.
What are they used for?
They're decent antihypertensives because blocking alpha-1 receptors on blood vessels leads to vasodilation, reducing peripheral resistance and lowering blood pressure. They also have a really useful second job relaxing smooth muscle in the prostate and bladder neck.
Ah, so good for BPH. Benign prostatic hyperplasia. Makes sense.
Exactly. Very helpful for urinary symptoms in men with BPH, but there's a significant warning with these drugs.
The first dose effect.
Yes, the first dose orthostatic hypertension. When a patient first takes it, especially if they stand up quickly, the sudden drop in vascular resistance can cause their blood pressure to plummet, leading to dizziness or even fainting. Needs careful dose titration.
Good warning. What about non-selective alpha blockers like phentolamine? Do they block both alpha-1 and alpha-2?
They do, and that non-selectivity causes problems for chronic use, especially for hypertension. By blocking alpha-2 receptors, which normally provide negative feedback to reduce any release, along with alpha-1, you get this massive vasodilation, sure, but the body freaks out.
How so?
The drop in blood pressure triggers a really strong reflex sympathetic activation. The heart rate skyrockets excessive reflex tachycardia. It kind of defeats the purpose for long-term blood pressure control and puts strain on the heart, so generally not used for chronic hypertension.
Okay, non-selective alpha blockade. That was too much reflex chaos. Got it. Finally, the beta blockers.
Yeah.
Huge class of drugs. Let's talk about the non-selective ones first, like propranolol. What's the main risk there?
The big concern with non-selective beta blockers, those that block both beta-1 and beta-2 receptors, like propranolol, labetalol, carvedilol, is in patients with respiratory issues like asthma or COPD.
Because of beta-2.
Exactly. Beta-2 receptors in the lungs normally cause bronchodilation. They keep the airways open. If you block these receptors with a non-selective beta blocker, you can cause bronchoconstriction, potentially triggering or worsening an asthma attack or respiratory distress. It's a major contraindication or reason for extreme caution.
Which logically leads to the preference for
Cardioselective beta-1 blockers, like metoprolol or atenolol. These drugs preferentially block the beta-1 receptors, which are mainly found in the heart. By sparing the beta-2 receptors in the lungs, they're generally much safer for patients with asthma or COPD, who also need beta blockade for cardiac reasons, like hypertension or after a heart attack.
selectivity is key to minimizing those dangerous side effects.
It's all about hitting the right target without causing collateral damage elsewhere.
What a journey. We've gone from the super fast ion channel nicotinic receptors all the way through the slower, more complex G-protein cascade to the muscarinic and adrenergic systems. This deep dive really highlights how these drug classes give us this incredibly precise chemical level of control over the body's automatic functions.
It really does. You can see the logic from the receptor mechanics right up to the clinical effects and side effects. And maybe that leaves us with a final thought, sort of a clinical puzzle for you to consider.
Okay, hit me.
We talked about epinephrine being absolutely critical in anaphylaxis, needing that beta-2 activation to open the airways.
Right, it's essential.
Now imagine a patient having a severe anaphylactic reaction, but this patient is also taking a non-selective beta blocker, maybe for high blood pressure. That drug is physically sitting on and blocking those crucial beta-2 receptors in their lungs. What happens then, physiologically, when you give them the life-saving epinephrine? How much is that beta blocker going to interfere with epinephrine's ability to do its job?
Oh, wow. That's a potentially dangerous interaction baked right into the mechanisms we've just discussed. It really connects everything.
It connects epinephrine from part 5 with the non-selective beta blockers from part 6. It forces you to think about the real-world implications of receptor antagonism during an emergency.
A really powerful question that underscores just how complex these interactions are in actual patients. We definitely encourage you to keep exploring that interplay.